So welcome everyone to today's session. We appreciate you taking the time to be with us. As Patricia said, the title of today's session is Integrated Care, the Nuts and Bolts of How Primary Care Providers Can Work with Behavioral Health. I am very happy to be with you today. My name is Javier. I am a licensed psychologist working clinically through the Healthcare Network and FQHC in Immokalee, Florida, which is in Southwest Florida. I also work with the Florida State University College of Medicine, where I am a clinical associate professor. And I'm very fortunate to have one of my dear colleagues with me here today, Dr. Salazar. I'll let him introduce himself as well.
Well, good afternoon, everyone. Thank you for having us, visiting you guys in telehealth, if you will, virtual. I am a physician, a pediatrician, and I'm the director of pediatric here in Immokalee. I work for the Southwest Healthcare Network of Southwest Florida. It's a federal qualified health center, and I had the pleasure of working closely with FSU through the psychology program, Dr. Rosado, and some of the fellows. We will talk in more details ahead of during the program, but it is an excellent program that we have together in benefit of our clientele.
Thank you so much, Dr. Salazar. So a little bit about us, I mentioned I work with the Florida State University College of Medicine. We have a pretty unique partnership collaboration with the Healthcare Network where we share a facility. Florida State University has a building in Immokalee, Florida, and the Healthcare Network runs a few of their clinical departments out of our building. And through our collaborative relationship, we're able to train medical students and other healthcare providers to then enter primary care and more specifically to work with rural and underserved populations. As part of our training program, we have a postdoctoral program for clinical health psychology where we teach psychologists in training how to work within an integrated care setting. We also have at our site the FSU Center for Child Stress and Health. This is one of 100+ centers that are part of the National Child Traumatic Stress Network, which is a network of centers funded by trauma. As part of our work, we create resources to help address the needs of children who are impacted by trauma and other adversities, and more specifically, children that are from agricultural families, migrant families, or children living in rural areas. But the focus of today's session is going to be about integrated care. So we're going to spend some time talking about a few models of integrated care. We'll go into detail in sharing with you a model of integrated care that we have implemented here, and specifically what we call clinical pathways that we have established to help patients access integrated behavioral health services. And then we're going to talk also about how we can contribute, or how integrated care can contribute to the treatment and prevention of chronic health conditions. But we're hoping that by the end of this presentation, you'll have a good idea of what are kind of the nuts and the bolts of what it takes to build an integrated care program. It's helpful to begin by talking about why integrated care. So what is the importance of integrated care? Why consider integrated care? So the question to that is at a basic level, as we all know, behavioral health is part of our health. I'm sure we all remember the biopsychosocial model, which calls us to address both the biology as well as the psychology and the social needs of a patient when they're coming in to receive treatment. So that means that we really can't separate mental health from the rest of an individual's care. It is at its core part of the healthcare that an individual, a patient, should be receiving. Why integrated care? Another important answer to that question is that without integrated care, mental illness often goes either undetected or undertreated by healthcare providers. We'll talk about some reasons for that, specifically among Latino populations. Why is it that certain populations have a harder time accessing care? But another important reason for integrated care is that the majority of patients really do not follow up with primary care referrals to mental health. One evidence of that is looking at the percent of primary care office visits that have some kind of psychosocial issue as a part of the treatment that's being addressed. Some statistics will say that up to 70% of primary care medical appointments have some sort of problem that has a psychosocial component to it. Statistics also show that over 50% of psych meds are prescribed in primary care. That's more true of adult medicine than pediatric medicine, but still the majority of psych meds are being prescribed in primary care. So in essence, our primary care system is our mental health system. And so even without all of the integrated care efforts, those mental health needs are showing up in our primary care practices. So we need to be better prepared to address those concerns. To give you an example, a colleague of mine, Dr. George Rust, when he is describing an encounter and everything that needs to happen during an office visit, and specifically when he talks about the example of obesity and diabetes, he shares this. To prevent complications of obesity and diabetes, all you have to do is modify a person's health beliefs and attitudes, their daily habits, their eating preferences, their daily activities, their exercise habits, their grocery store, their neighborhood walkability, food advertising, self-care, employability, economic empowerment, access to medical care, provider quality, medication adherence, and then you have to do all of that in the context of his or her family and their social relationships. And not only that, you have to do it in the confinement of a 15-minute office visit, and oftentimes a visit that's already double booked. And so we don't necessarily have all of the time for one healthcare provider to address all of these things, especially with the restrictions that are in place. And so there is not only room, but there is a need for integrated care in order to really be able to address all of the issues that need to be addressed if we're trying to consider the disparities that many of our patients present with. There's some data that helps us to understand how effective is integrated care. There have been several meta-analyses that have been conducted that have shown effectiveness both for adults and children and adolescents. Effectiveness is typically measured by changes in two areas. So first, improvement in symptoms, but second, and more importantly, improvement in functioning. And so improvement in functioning can mean things like improving in adherence to chronic disease management. That's one thing that's really important about integrated care, is that integrated care programs are most effective when they are targeted. That means that you choose a particular focus area that you want to improve and measure outcomes on. And most often the focus is when there's a comorbid medical and mental health condition. But the point here is that integrated care is effective. It's effective at improving symptoms, but it's also effective at improving a patient's level of functioning. Now, not only is integrated care effective for general populations, but there is a particular area where for Latino patients, integrated care can have a significant impact. First, integrated care is very problem focused. And so when you come in and you receive integrated care services, this is not your traditional psychotherapy where you're coming in for 60-minute appointments for several months at a time. We understand that for many of our patients, that is not something that they can realistically do. And so integrated care services by design are very focused. And so that's a benefit to our population who oftentimes doesn't have the means to come for that long traditional therapy that most of us have known of in years past. Access to integrated care services is also an added benefit for Latinos. During today's presentation, we'll talk about warm handoffs, which essentially is when a patient is introduced to behavioral health services during a medical office visit. This means that when our patient comes to receive care, they're not having to schedule an extra or an additional appointment just to be referred to behavioral health services. Oftentimes they're able to access the service on demand, real time. And so that's an added benefit. Because integrated care services are provided within a primary care setting, there's decreased stigma. We can also use the benefit of integrated care services to decrease disparities, to improve chronic care management. And a very important outcome of integrated care is improved satisfaction of care. There have been studies with national samples of Latinos and especially immigrants from Central America that have shown that symptom presentation among this population looks different, and the way in which they access care is also different. For example, many of the patients that we treat are less likely to meet the diagnostic criteria for a mental disorder. It does not mean that they come without concerns. It doesn't mean that they don't have symptoms that need to be addressed. It just means that the way the symptoms appear, they are less likely to meet the diagnostic criteria for a particular mental disorder. One reason for this that you find in the literature is this concept of stoicism. Stoicism means that oftentimes patients will present with this extreme resilience, as if even the worst of adversities or traumatic experiences hasn't impacted them in a way that's good, because we see the resilience, we see that protective factor in place, but also that means that we may have to work a little bit harder in our assessment to determine what symptoms actually exist. I know that myself, as a behavioral health provider, I've confronted that so many times, where when I hear a patient's presentation and I hear their history of adversity and trauma, I see someone in front of me that is very strong, very resilient. I don't automatically see the symptoms of depression or anxiety. They're not crying, they don't seem depressed, they're actually smiling, they're resilient. That doesn't mean that they haven't been impacted by trauma. That doesn't mean that they don't have mental health needs. It's just that the presentation is different. But I share all of that to say that, again, Latinos are less likely to meet the criteria for mental disorders. They're more likely to be diagnosed with mental health diagnoses such as adjustment disorders. And so access to mental health services, specialty mental health services, or referral for those services may happen less often. So if we're able to provide services in-house through integrated care programs, that means that Latino patients are going to be able to have better access to the care that they need. So we're building a case, right, for, why should we consider integrated care? How is integrated care effective? But I think oftentimes it's helpful to take a step back and just answer the simple question of, what is integrated care? So there's no nationally recognized definition of integrated care that everyone is going to adhere to. But what is common is that the term is used to describe efforts to provide healthcare services that bring together all of the components that makes a person healthy. So this includes promotion of health. It includes a variety of factors like psychological factors, biological, social, economic factors as well. But integrated care can really look different based on the setting where the healthcare delivery is being provided. So today, what I want to do is share with you a perspective of what integrated care looks like and what are some of the essential components. So what you see on the screen is a concept that we adapted from the Collaborative Family Healthcare Association, which talks about integrated care composing of 3 essential elements. First, integrated care programs should be rooted in a particular perspective. They should include clinical pathways, and then there should be models of care as well. So the perspective of an integrated care program, what you see at the bottom, so the root of the integrated care program really should be an approach or a framework that guides and feeds all of the integrated care efforts. This is kind of like a guiding principle of an integrated care program that then results in the development of specific models and or clinical pathways. But we want to remember and understand here is that an integrated care program should be rooted in a particular perspective or a framework that guides its program. There are different perspectives that different integrated care programs may select or adopt. Today, we will share an example of our integrated care program where our perspective includes ACEs, or adverse childhood experiences, and trauma-informed care. So we'll talk about that as an example. An integrated care program should also include clinical pathways. So these are algorithms that are used to guide care to ensure that patients with specific conditions receive monitored and timely care. So today we're going to highlight examples of 2 clinical pathways that we created in our system. And I'll talk more about this, but I'll say that these clinical pathways are sometimes missing in integrated care programs. We'll talk in a moment about different models, but usually when we think of integrated care, we think of having a behavioral health provider that is available to a primary care team. That certainly is part of integrated care, but integrated care should also include these clinical pathways where, again, we make sure that specific patients with specific conditions are receiving timely care. And then we also have models, as you could see at the top of this diagram. So models are delivery strategies that prescribe specific ways in which professionals will work together to provide healthcare services. This is what defines how the different healthcare providers will work together. So next, I want to walk through each of these steps. I want to give you some examples of models, clinical pathways, and perspectives. We'll start first with models. So there are different models of integrated care, and that term integrated care is often used to describe different models. So we have at the far left here a coordinated care. So some people will use the term integrated care to define what really is coordinated care, which is when you have a primary care doctor referring a patient to a psychologist or another mental health provider who is located in a separate building. So they work for 2 different agencies. The primary care provider will send the referral, and then you have the behavioral health provider who then responds with evaluation information and or treatment updates. That's what we would call coordinated care. Then there is co-located care, which is a step closer to bringing behavioral health and primary medical health services together. In a co-located care model, you would have a behavioral health provider who is located in the same building, but keeps separate medical records or separate charts. So they are working in the same building, but each keep their own medical records. You would still have some communication between providers in that the behavioral health provider would send reports and updates to the primary care provider. But they're essentially working independently, each have their own treatment plan, but will communicate back and forth when they have a patient in common. And then there is primary care behavioral health. In a primary care behavioral health model, here you have a behavioral health provider who is part of the primary care team. So they share essentially everything. They share the same space in the same clinic. They consult with each other on cases. They develop a common treatment plan. They document in the same medical record. They share the same support staff, meaning the same reception staff, the same check-in staff, the same scheduling process, the same billing staff. So it's really one system, one team where you have the behavioral health provider working together with the primary care provider, again, sharing the details of the patient's care from treatment plan all the way through the support services that are received. Now, these are the models that I usually recognize and see most often in different community health centers when we use the term integrated care. but you will see in the literature that there are other models. This is not an exhaustive list. For example, there's the collaborative care model, which is specially designed for patients with depression. And in that model, there's the use of a psychiatrist who consults, and there's also a care manager who helps to manage a registry or a list of patients from a particular practice who have been screened as needing support for depression. So there's that collaborative care model as well. But the point that I think is important for us to understand here is that the term integrated care is used to describe different models. Today, we're going to describe primary care behavioral health, and that's what we mean by integrated care. So we've talked about the models. We know there are different models of integrated care. And next, I want to talk to you about perspectives. And again, this is the root of an integrated care program. I think it's important to talk about perspective before we talk about clinical pathways, because this is what really should guide our clinical pathways. So again, a perspective is the approach or the framework that will guide and will feed integrated care efforts. This is kind of the guiding principle of an integrated care program. So in our integrated care program, our perspective or the roots of our program are ACEs, or adverse childhood experiences, and trauma-informed care. So I'll briefly describe that for you to give you a context of what our integrated care program aims to do. So our main perspective is trauma-informed care. So in trauma-informed care, what we're aiming to do is provide healthcare services that understand what is the impact of trauma, both the impact of trauma on someone's health and well-being, but also the impact of trauma on an individual's mental health. So we know that for our population, in our case, we serve a highly agricultural community. Many of our patients are immigrants to the United States. Some are recent immigrants. In recent years, we're receiving families that are leaving their home countries to escape things like violence, extreme poverty. And oftentimes our patients present with a history of some very traumatic experiences. And so our aim is to offer healthcare in a way that recognizes that they may have been exposed to traumatic experiences, and we understand that those experiences, again, impact their well-being, both their health and their mental health. Within our system, we want to recognize the signs and symptoms of trauma, and we aim to adapt our policies and procedures to allow for the recognition of that trauma and to give us the space to respond in a trauma-sensitive manner, and most importantly, to avoid re-traumatization. If we're not careful and aware of trauma and its impact, the way in which we deliver care could trigger some of the traumatic experiences that some of our patients may have had. And so again, the root or the perspective of our integrated care program is to recognize that our patients come with a high prevalence of trauma, and our aim is to respond in a trauma-informed way. So one of the ways that we do that is by rooting our integrated care program in ACEs, or adverse childhood experiences. Many of you, I'm sure, are familiar with ACEs. There was a study that was done in the late 1990s at Kaiser Permanente that identified 10 adverse childhood experiences that are said to increase a person's risk for developing chronic health conditions during adulthood. And so on the screen, on the left-hand side, you see that there are 3 different categories of adverse childhood experiences: abuse, neglect, and household dysfunction. These were the original 3 ACE categories that were identified by the ACE study in the 1990s. Within these 3 categories, there are 10 ACEs. The original research showed that when an individual experienced 4 or more of these adverse events during childhood, then you would see a significant increase in chronic health conditions during adulthood. So as you could see, this includes any form of abuse, neglect, and then household dysfunction such as domestic violence, substance abuse, divorce, separation, incarceration. So we know from research that individuals who have been exposed to these ACEs are at a higher risk for chronic health conditions. And so we want to respond in a sensitive way to these conditions and address ACEs earlier on in life. In addition to the 10 original ACEs that were identified in the 90s, we know that that's not an exhaustive list of ACEs, and we know that our population oftentimes comes with unique exposure to other adversities, including things like deportation fears, family separations or threats of family separation. For our migrant families, a transient lifestyle also represents an adversity, and for some that could be traumatic, especially during childhood. Inadequate housing, experiences with discrimination, and then historical trauma as well. Historical trauma has to do with an individual's response to traumatic experiences that generations prior have had. So if my parents, for example, were exposed to war or extreme violence or poverty, I may have been born after that. However, I still experience their trauma. So a generation after those events can still experience some of those traumatic events. So we want to be really aware of ACEs and these other adversities. This is what really guides our integrated care program. Why do we want to be so aware and responsive of this? It's because of the risk for chronic health conditions during adulthood. So on the screen, you see a list of the most common physical and mental health problems that are associated with high ACEs. This includes things like obesity, diabetes, depression, STD, suicide attempts, stroke, cancer, COPD, broken bones. Again, research shows that the higher the number of ACEs someone experiences during the childhood, the higher the risk for these chronic health conditions. So I want to hone in on diabetes for a moment because it is such a common concern among our population. And I'm sure many of you as medical providers spend your time trying to address diabetes. So I want to talk for a moment about how do you get from ACEs or adverse childhood experiences to a diabetes diagnosis? What does one have to do with the other? So research has shown that there are specific ACEs and variation in intensity of ACEs that impact the development of diabetes. For instance, childhood sexual abuse is strongly linked to diabetes in adulthood. There have been a couple of research studies that have been published looking at this relationship. One showed that someone who has experienced sexual abuse has a 1.5 to twofold increase risk of developing diabetes during adulthood. There was another study that showed sexual abuse victims 45% of them were more likely to develop diabetes when compared to 14% and 18% for heart disease. So there's something very particular about the experience of this traumatic event of abuse that places an individual at risk for developing diabetes. And so there are some models that have been proposed to help us understand, again, how do we get from an ACE event like sexual abuse to a chronic health problem like diabetes. So I'm showing you one model now that shows there are two potential pathways that could help us understand how we get from the ACE to diabetes. So first, there's the physiological pathway. And this pathway shows that chronic stress that occurs because of the abuse can lead to inflammatory and metabolic alterations. This physiological pathway also explains that a person may experience depression as a result of their abuse, which, we can anticipate that. But because of the depression, then there are alterations in hormone release and glucose functioning that then lead to insulin resistance and eventually to diabetes. So we have that physiological pathway. There's also this psychosocial pathway, which shows that accumulated risk factors for poor health behavior then impact overall health and outcomes over time. So this has to do more so with how do we cope with the ACE event or with the adversity. So if I experience abuse and I'm feeling depressed, I may find some unhealthy behaviors to cope with my depression. So maybe it's smoking, maybe it's alcohol abuse, maybe I respond by overeating because that helps me regulate my emotions. But there's a behavioral or psychosocial pathway that then places me at risk for the chronic health problem or diabetes. And oftentimes it's really the interaction of these two pathways that significantly increase our risk for diabetes. So I'm sharing this information to, again, explain what is the root of our integrated care program, and our perspective is ACEs and trauma-informed care. And the reason for that is this, is we understand that individuals who are exposed to ACEs and other traumatic experiences are at a much higher risk for developing these chronic health conditions. And they also are more likely to have comorbid mental health problems. So you'll have someone who has diabetes, but they likely also present with symptoms of depression and or anxiety. And so that is the root of our program and what really guides our program. So now going back to our model, I want to talk about clinical pathways. So now that we know what are ACEs and their impact on health, we want to talk about how do we get patients who are impacted by ACEs and trauma integrated healthcare services. And that's really what clinical pathways are all about. It's about making sure that a particular set of patients are getting the care that they need. So particular patients with a particular condition receive monitored and timely care. So we are looking for pathways, opportunities in the patient's care where behavioral health can be integrated into their care. We're not leaving it up to chance whether or not someone will receive integrated care services, but we are creating a pathway for someone with a particular condition to receive services. In our example, the condition we're targeting, again, are ACEs and traumatic experiences. I'll also show an example if time allows today of postpartum and maternal depression. So let's talk about our trauma/ACEs clinical pathway. What we have done in our integrated care program is we've implemented routine screenings in pediatrics for ACEs and traumatic experiences. We have integrated these screenings during well-child visits. So when a family comes with their child for their annual physical exam, the family is directed to a computer or a touchscreen device. So we have a kiosk that we set up in our waiting room. We designed a screening software platform to help administer these ACE screenings. So we have a modified ACE questionnaire that we've developed. We also include several other measures as part of our screenings, including the PHQ-A for adolescents. We use the child symptom checklist as well, the GAD-7. So many of the tools that you're likely already accustomed to using in your practices, we've incorporated that into our electronic screening. But the focus here is screening for ACEs and other traumatic experiences. And when a family comes in for their child's well visit, they're directed to this touchscreen device where they answer a set of questions. They could do that in their language preference for low literacy populations or even those who are unable to read. We have audio prompts that will guide them through the screening. They'll answer the questions. The screening software will score their responses and will generate a report that is then sent into the electronic medical record. So we begin with this computerized screening. When the nurse is taking vitals, the nurse will do a brief review of critical items. And if there is a positive screen or high priority positive screen, the nurse will make an announcement. So we use a walkie-talkie system. Behavioral health providers have access to that system. The nurse will announce when there is a positive screen, will share the room number where the positive screen could be found. The psychologist will then review those items, will go into that office visit and will consult with the family. We'll do an initial assessment to determine the nature of the ACE, what the needs are for their treatment. Oftentimes, the behavioral health provider will go into that exam room prior to the pediatrician initiating the physical exam. In some cases, depending on the workflow, the pediatrician may go in first, but typically it's the behavioral health provider. So the behavioral health provider will do a consultation with the family to follow up on the positive screen. Following that consultation, we have a team consultation. So this is typically the behavioral health provider and the pediatrician will discuss the findings that were obtained by the behavioral health provider and will review the screening results. And then the medical provider, pediatrician, we'll continue with the 12-child visit. At the end of that visit, then we determine what is the appropriate response. In some cases, it may be physician guidance in addition to the behavioral health information that the behavioral health provider would have already given. In some cases, we may agree that, yes, this is a case where behavioral health treatment is needed, and that behavioral health provider will then initiate treatment as well. I'm just giving you kind of a quick run through of what our algorithm looks like. But the most important point here is that we are, again, looking for patients who are impacted by a particular condition, in our cases, ACEs or trauma, and we are designating a pathway for those patients to receive care for their condition. And we have very specific points in the patient's care where behavioral health is integrated. So behavioral health is automatically integrated into the care of the patient. So I'll pause here for a moment, and I'll ask Dr. Salazar to step in and maybe talk a little bit about his experiences with integrating behavioral health into the screening process. If he could talk about any hesitations, Dr. Salazar, that you remember at the beginning, or any barriers, or just kind of in general your experience with this algorithm.
Thank you, Dr. Rosario. As a person, as a physician, that I have worked on those extremes, one, when we used to work without complete lack of behavioral health psychologists, we were part of the psychology, whatever little we could do. And as a person that now works in a very close relationship, and thank God for that, with the FSU and the team of psychologists that Dr. Rosario had, I can tell you, and I only here to reassure and to reinforce the idea that Dr. Rosario just put to you guys. And that is a benefit to everyone having the behavioral health in-house, we call it, meaning here in the same building. I mean, I don't want to put anyone down, and the other people for different reasons may be in different buildings or may be in work in different settings. But I just wanted to emphasize what Dr. Rosario said. Having in the same building, it had been something out of this world for us. When I talk to younger colleagues of mine, and I explain how we used to practice before the behavioral health, they look at me with an strange face and say, how could you practice without having the psychologist right by the hand? And I mean, just as a matter of speaking here, I mean, this is my office, and 2 offices down the road here, and in the same building, there is a psychology fellow that helped me, and I grab every time that I need something. So it's amazing in talking about the people that we serve, Latino population. They are on one side shy, they are on the other side the machismo that we call it. They don't confess themselves to the doctors, and they come only with the idea that they're only going to find health from the medical point of view. To my surprise, it's amazing the numbers, how they have increased since we start digging into the mental problems. I strongly recommend to people listening to us today, give it a try, and you will see how you could help much more the population that you serve. It's amazing to me how they appreciative are once we get to the point. I mean, I have found so many cases that I could be talking to you for hours during my years here with the help of behavioral health, that without them, I could be completely blind, in other words, in reference to that. And it's when we start digging into that mental problems that we have found so many multiple things that we have helped. And the benefits, as I said, is for the patient itself, is for the family, for the physician, and the psychologist. How, as a team, we work together, helping the population that we serve. I don't know if you, there are some little things that nothing comes complete without problems. And I'm one of them that I had at the beginning of it. I have my reservations in reference to time consuming when we have that tight schedule that we run, and the time consuming was like the patient. I'm ready for the patient, and the patient is still answering the questions outside. They don't understand. Sometimes you need an assistant. You have to make a few modifications in order to go ahead with that. However, I have to tell you this: at the end, it pays up, because for 5 minutes, 10 minutes that we lose, sometimes we are in a hurry and we didn't realize that the benefits are at the end of the tunnel. And that's what everybody is here for, to benefit the population that we serve. Thank you, Dr. Rosado, and you can continue.
Yeah, thank you. Yeah, I think Dr. Salazar alluded to the fact that in many cases, when we've implemented this integrated care program, and specifically the screenings, we have been surprised at some of the findings. I mentioned at the beginning of the presentation that many patients present with this stoicism, meaning that this extreme resilience that in terms of their mental health and the stressors and traumas that they may be coping with, they're not obvious, or they're not apparent at the beginning. But then when you ask the question, when you go through the screening process, then you're able to identify some significant needs that would have been missed if we weren't really strategic about screening for our focus area and then providing the needed response, which is integrated care. If anyone who's participating today has any questions or comments, feel free to type them in the chat box, or even if you want to unmute yourself and speak up. We will reserve some time at the end to answer questions, but don't feel like you need to wait until the end. Feel free again to type your question into the chat box, and we'll stop and address your comments. So we've been talking about one particular clinical pathway, right, which is ACEs, or trauma screenings. I want to give another example of a clinical pathway to again designate points in a patient's care where behavioral health would be integrated into the treatment that they are receiving. So this is an example of women's health. Let me come over to this example. Our integrated care program in women's health has kind of evolved over time and has looked different in different times of our program. And we're actually currently in the process of updating how integrated care looks within women's health. But this is a variation of what our integrated care program has looked like over the years in women's health. What you see here are different points during pregnancy where behavioral health is integrated into the care that the expecting mother is receiving. So you see here specific points in time where a patient would automatically receive behavioral health services. So during a first prenatal appointment, there would be an introduction to behavioral health, along with a screening to identify any behavioral health needs or any issues that may have gone on that could impact the pregnancy. So for all expecting moms, there is an interaction with behavioral health. This could happen at different points during the care that the expecting mother is receiving. It could be during your initial intake appointment, or it could be when they are with their provider. The provider could do a warm handoff to the behavioral health provider, who would then come in and complete this initial prenatal appointment. If there is an identified need for ongoing behavioral health services during this prenatal appointment, then those services will then be provided individually to that patient. However, if there is no identified need during that first appointment, then again at 36 to 35 weeks, behavioral health is again integrated into that appointment for a repeated screening and or follow-up to any needs that were identified during the initial appointment. Again, behavioral health is integrated into the care 2 to 3 weeks after delivery and during the postpartum appointment as well. During these encounters, there's additional screening that takes place for any symptoms of depression, also for any psychosocial needs that may have arisen during the pregnancy. And then eventually we transition over to the well child appointment, where now when the child is being treated during the child's appointment, if there's a need in terms of the mother's mental health, it's then followed up in pediatrics and linked back to women's health. But there are, again, very specific moments in time during the patient's care where behavioral health is integrated. And our objective here is to identify any signs of depression or any psychosocial needs that could impact the pregnancy. Now, in addition to these encounters with behavioral health, there is a team of people that are working together to ensure that the patient's needs are being met. So throughout pregnancy and even after delivery, we've hosted what we've called Mommy and Baby Group. This is a group that is facilitated by a mental health provider, again, during and post-pregnancy. Its original intent was to be a group for depression and postpartum depression. However, it kind of evolved to addressing greater mental health needs. And it was really targeting mothers who maybe felt unaccompanied during the pregnancy process, or who had other risk factors for depression or postpartum depression. And so that was an additional support or service that was available for our patients. In addition to that, our outreach department would be available to conduct any home visits upon request for a provider. If there was a concern about the patient's mental health, they would be able to make that visit. But then they would also do a courtesy home visit, typically after delivery, and would administer a postpartum depression screen as well. So this is a brief example of how we've integrated behavioral health into women's health and during the pregnancy process specifically. But again, the point that I want to reiterate is that within integrated care, there should be these clinical pathways that designate when a patient is going to have a behavioral health encounter. A behavioral health encounter should occur according to this algorithm or clinical pathway. And those encounters, again, should be rooted in a particular perspective that your integrated care program has adopted, whether it be ACEs or trauma or whatever other perspective you feel is a priority within your healthcare system. Now, outside of this algorithm, there are other common presenting problems that a behavioral health provider who's integrated into the practice can help with. Here are some examples of other problems that may benefit from integration in women's health. So for chronic illness, it would again be things like asthma, diabetes, cancer, pain management. We can also integrate behavioral health into overall wellness. So teaching things like stress management, responding in the case of an unwanted pregnancy, coping with adverse diagnoses, issues related to occupational health, and then comorbid mental health and medical concerns as well. So definitely helping with depression, anxiety, issues of domestic violence, trauma, as we've spoken about as well. So in addition to having these algorithms where behavioral health would be available to specific patients, behavioral health can also step in to help address some of these other presenting problems that commonly come up during primary care office visits. I'll share one more example, but for pediatrics this time, there are several presenting problems that are very common in pediatrics where behavioral health could be very useful. Again, chronic illness, things like diabetes, asthma, obesity, cancer. In our practice, we focus a lot on obesity, and our integrated care program helps respond to that, sometimes on an individual basis, but the bulk of our work for obesity is done in a group format. So our behavioral health providers work together with our medical providers to identify families who are impacted by overweight and obesity. And we've developed a program where we then help to address their needs. Well child visits, as I mentioned, we have trauma or mental health, ACE screenings that take place during well child visits. But for those of you that are pediatric providers in the room, you know that you spend a lot of your time giving preventative information, parenting advice. There's room for behavioral health providers to also contribute to that education that you typically provide during well child visits. And then, of course, the mental health concerns that oftentimes show up in primary care. In pediatrics, it would be ADHD, depression, behavioral problems such as oppositional defiant disorder, and then other social or even school stressors that come up and families will bring up during a visit with the pediatrician. So I'm trying to give some examples of how behavioral health could be integrated to address some of the common problems that come up during mental health or during primary care office visits. I think this may be a good time for Dr. Salazar to also comment as a pediatrician, what are some of the presenting problems where you have found it most useful to have behavioral health available and integrated into your care? I think you might be muted, Dr. Salazar.
Good afternoon again. As Dr. Rosado was saying, everybody listening to the talk knows that I'm on the left-hand side of the screen that you can see obesity. That is a main problem for us. The Latino, the factor of the obesity is not as terrible as if it is considered by the providers. Obesity is sign of a health among the Latinos, and they never complain about the eating habits of the person except when he's completely overweight. But one thing that I wanted to insist that just to describe a scenario here that just happened about a week and a half ago, and Dr. Rosado may remember this, a young adolescent came to see us for a well visit. And what happened to that? The child, the person, the adolescent is sitting. By description, the mother said he's a shy person. She doesn't like to talk. She doesn't smile that much. She has few friends. And that will go, and the doctor will focus on finding, okay, lay down, do the physical examination. I don't find anything. Okay, well, we'll check your vaccines. We'll give the vaccines. Your weight is excellent, okay? Your blood pressure, your vital signs are perfect. And I will say, okay, the nurse is coming. We're gonna order some tests for you. And maybe next year you will smile more to me. And we go into that area and say goodbye, wish you the best. Reality of life, reality that I have lived so many times, that person, it was completely depressed. Didn't want to say anything, didn't confess to the parents, anything, having problems in the school, bullying in school, all of those little things is a blessing for us, as I said, to have the integrated care together with the behavioral health. I can go, as I said before, time and hours and hours describing to you how many times I have been surprised by the fact that we go as a physician, we focus on the health of the person, but we, most of the time, not now, but most of the time, we forget about the mental health of the person. Nowadays, especially with this past year, with the coronavirus, has been tremendous help, the behavioral health for all those kids that are missing the school, the contact with the friends. They get depressed. It's so many that we have seen that I strongly suggest and insist that integrated health, meaning mental health and physical health, is excellent. The other things that we see here, the diabetes, the asthma, the cancer, I mean, all of those are listening. They know what we go through on all those, and I'm not going to bore you with those, but the mental health is so important nowadays. Thank you, Dr. Rosario.
Thank you, Dr. Salazar. So how does this work? I've given you some examples of times in the patient's care where a behavioral health provider will just kind of show up because it's part of the algorithm. So I gave the example of during physical exams, we do these screenings. If you screen positive, behavioral health will just kind of walk into that exam room and we'll follow up on that positive screen, consult with the pediatrician and or primary care provider, and then come up with a treatment plan accordingly. So when we are built into the algorithm, there's already a designated time for behavioral health to step in. However, outside of that algorithm, and for some of these other presenting problems like obesity or asthma, behavioral health can also be available. And typically the way patients access behavioral health is through a warm handoff. Many of you may already be familiar with what a warm handoff is, but essentially it's when the primary care provider will introduce the patient to a behavioral health provider. And I'll come back to this slide in a second. But basically, the primary care provider gives a brief introduction of the psychologist. There are times in our schedule, so I, as a psychologist, the way my schedule is set up, I do have follow-up appointments that are scheduled throughout the day, but I also have gaps in my schedule so that I can be available for warm handoffs and so that I can respond to any positive screens that come up. So my schedule is built in such a way that if there is a primary care provider who needs to introduce me to a patient, I can briefly pause what I'm doing, step out of my office, go into the exam room, and then have the primary care provider introduce me to that family. Depending on, again, the workflow and my own schedule that day, that initial warm handoff may be just that brief introduction where the primary care provider will put a face with a name and will say, hey, this is Dr. Rosado. He's the psychologist. He's the mental health provider. He can help you address some of the issues that we talked about today. If it's a day where I am busy and I have other patients waiting, I may just do that brief introduction, say, it's very good to meet you. I look forward to working with you. Dr. Salazar has shared with me some of your concerns, and I think we could do, X, Y, and Z to help with that. That at a minimum, that will happen for every encounter that's needing behavioral health. Now, if that warm handoff happens to occur during one of those gaps in my schedule, then I would stay with that family. I would either stay in that exam room and begin an intervention if the exam room is available, or I may ask that family to follow me to the space that I use. So I have an office that I use. Some other integrated care programs have what they call talking rooms. And these are rooms that are designated for office visits that may take a little bit longer, or if there's any follow-up that's needed after a clinical encounter, you can ask the patient to then go into this talking room. But if I am getting that warm handoff during one of those gaps in my schedule, I will ask that family to then follow me, and I will begin an intervention or an assessment on that same day. And we try to do that as often as possible in order to increase access to care and to take advantage of the time that we have. We know for many of our families, it's difficult to get time off work. It's not easy to make it into the clinic. And so we want to offer every family something to walk away with, some kind of tool, coping mechanism that they can then implement when they leave. But at a minimum, it is really important to do this brief introduction or warm handoff that occurs from the primary care provider to the behavioral health provider. Research shows that that warm handoff is essential in increasing adherence to follow-up treatment. If a patient meets me as a behavioral health provider, they know who I am, they see my face, they're more likely to return for the follow-up office visit with me. Without that warm handoff and relying simply on an order or a referral, patients are less likely to return for care. So it's really important to offer that warm handoff. The concept of a warm handoff, it's pretty self-explanatory, but sometimes it's nice to see what that looks like. So I have a very brief video of a warm handoff that I could share with you. It's about 2 minutes or so. But if in interest of time, before I show the video, I want to pause for a moment and see if there are any questions in the audience, comments, or perhaps any other information that you were hoping to hear today that you haven't heard quite as much as you would like, that maybe we can speak to. If anyone would like to type questions or comments in the chat box, we'd be happy to take some time to respond to those now before I play the video. I see that there's a question about our ACE screener. Someone's asking if we could share the ACE screen that we use. I'd be happy to share that. I believe there's a portal where I can upload resources. I uploaded the PowerPoint to that portal, so I will upload our ACE screener to that portal. But if for some reason you're unable to access it from there, in a moment, I'll include our contact information. And if you email us, we'd be happy to share the tool with you. Yeah, I see somebody's commenting on the warm handoff. Blanca's mentioning that she sees how that would make a difference for families, and it absolutely does. Again, that interaction with the behavioral health provider oftentimes puts the family at ease. We know there's some stigma about mental health and psychology. So meeting a mental health provider and seeing whom they are often places that family at ease and helps them to come back.
If I may?
Yes, please.
One interesting and valuable thing about the handoff is the fact that sometimes mental problems comes in waves. And if you touch base with the patient at that point in time, maybe he's willing to open up instead of just sending me out and tell them, make an appointment with a behavioral health person. That person may not come back. That person may change her mind or his mind. One of the good things that I have noticed on the handoff is that I bring you in, I bring any fellow or somebody from behavioral health, and at that particular time, they open up. I have seen that. I mean, I haven't seen the other side because I don't know, but I figured that at that point in time is interesting and valuable for that patient to open up if they accept. When I said to you, I would like to introduce you, just in case that you're really willing to open up and talk to them. If you don't mind me 2 minutes, I will bring out the fellow, Dr. Rosado, to talk to you. And guess what? I think that is beneficial for everyone again. And they open up on that moment. We don't lose the opportunity and we don't miss the opportunity to help that person. Thank you.
Yeah, and I think what happens is that then the behavioral health provider just becomes another provider. They meet that person, they know that they're present, they're available, as Dr. Salazar said. If the presentation of symptoms maybe subsides and they don't come back, but then it resurfaces in the future, they know who the behavioral health provider is, how to access that provider. That is oftentimes a benefit of integrating behavioral health into well visits. There may not be a particular behavioral health concern at the time of that visit, but then the family would have had an encounter with a behavioral health provider. And so they know who the provider is, they know how to access the provider, and it increases the likelihood that they will seek care if symptoms or a need arises later on. Okay, so I'm going to show you the video example of a warm handoff. Again, if anyone has questions, comments, or anything else related to integrated care that you would like for us to comment on, feel free to type your comments in the chat box.
Okay, Victor, how are you doing?
Doing good today, sir.
Okay. Victor, we have been working for several weeks.
Mm-hmm.
We made a plan for you, and you were willing to work on diet, exercise. I was checking your chart, and I see that you have lost weight in the initial weeks, but all of a sudden have stalled, and you're not making more progress. What's going on?
I feel that I don't have much support at home. That's what I feel is mainly the cause why.
When you say that you don't have that much support, or they were looking for more support, what
Like,
might
I try eating healthy, and my parents, they keep trying to feed me more greasy food, or if I tell them no, I don't want to finish it all, they make me finish my whole plate.
Okay, so they're trying to please you because you know that's the way our culture rewards good behavior by inviting to eat, and sometimes they might perceive that you're not eating enough.
Yeah, they sometimes think I'm getting too skinny, that I'm not eating right enough, so they try to feed me.
Right. Victor, do you think that it would benefit if we can invite Dr. Farias, a good friend, a colleague that is a psychologist that might help you with some strategies to deal with your family? Would you like to invite her?
Yeah, I think that'd be really helpful.
Okay, let me just call her in a minute, and I'll be back in a second.
All right, thank you.
Victor, I'm back. Victor, I want you to introduce you to Dr. Farias. Dr. Farias is a colleague of us. He's a psychologist. Victor has been working with us for several weeks, almost a couple of months, and he has lost weight, but is struggling to keep up with his plan. He's telling me that he would like to have more support from the family. I'm concerned that there are more around the family elements or situations that might be making difficult for Victor to follow up his plan. So I will let you talk, and we'll take it from there. Okay?
Hi, Victor. As Dr. Bryan mentioned, my name is Dr. Farias. I'm one of the psychologists here. So I'm glad to hear that you've been making some changes to improve your health. Good job. So can you tell me a little bit about how you want your family to support you a little bit more?
I think.
Okay, so I'll pause there. So this was obviously an example about a primary care provider who was addressing overweight or obesity and eating behaviors related to the adolescent's weight status. What's really important about how this warm handoff was done is that the primary care provider summarized to the behavioral health provider the reason for the warm handoff and did that in front of the patient. That is really important. That helps everyone be on the same page. It really helps us as the behavioral health provider in terms of understanding what is the need, and to know that the patient and the behavioral health provider and the primary care provider all have the same understanding of why this integrated care encounter is taking place. And as you could see, the behavioral health provider only played a few seconds of it, but as the behavioral health provider began speaking, she picked up right where the primary care provider left off. It was a very smooth, seamless transition. Her consult was very targeted, right? She went straight to the issue, which was, my family's not supporting me. That's very different from what a traditional mental health encounter would look like, where typically you would have a lengthy intake, you get a lot of information about family history, treatment history, all of those things are important and more important in certain contexts or situations. But here in this warm handoff, the treatment and the reason for the referral was really targeted. And the psychologist, again, in this example, picked up right where the primary care provider left off. That's the importance of that warm handoff and of doing that introduction where all three parties are present, the patient, the primary care provider, and then the behavioral health provider. So, going back to our integrated care tree of models, pathways, and perspective, if you remember anything from today's presentation, there's just kind of a few things that I would highlight for you. The first is that if you're building an integrated care program or even evaluating the integrated care program that you have now, it's important to ask yourself, what is the perspective of our program? What's the foundation, the guiding principle of our program? That's really important in order for your program to be effective. What guides it? What is the framework for it? We gave you an example of our framework, which again is trauma-informed care, ACEs. Once you have a perspective or a framework, your integrated care program then has its roots and it can flourish from there. The next step would be to choose a model. So what's going to be your model of care? We attempted today to describe a primary care behavioral health model where primary care providers are working together with behavioral health providers. The behavioral health provider is part of the team. That is different from co-located care or collaborative care. We are talking about primary care behavioral health. And then most importantly, integrated care programs should have these clinical pathways that designate specific patients that present with a particular condition would have a set time during their treatment where behavioral health would be integrated. Again, we're not leaving it to chance. We are creating an algorithm to determine when particular patients are going to receive integrated care services. And of course, those points in time are rooted in the perspective that you've adopted for your integrated care program. I want to finish off with our contact information. There's a phone number and email address if you have any follow-up questions that you're unable to ask now. We also have a website, the FSU Center for Child Stress and Health. Our website is fsustress.org. I'll type that in the chat box in case you're unable to see it on the screen. fsustress.org. On our website, you'll find a variety of resources, including psychoeducation related to behavioral health and mental health, and specifically those that address the needs of our population. We address issues like grief, deportation, separation, and the majority of our resources are available in English, Spanish, and then also in Creole. So feel free to visit our website or send us an email or call with any additional information that you'd like to request. We still have some time left. We wanted to leave some time at the end to, again, answer any questions that you have or take any comments. So if you do have any questions that you'd like to bring up, again, feel free to type them in the chat box, or you may also unmute yourself.
While we wait to see if some questions come in, I just wanted to take a moment to draw everyone's attention to the chat box where the link to the survey has been posted. And so when you have time, take a minute to complete the evaluation. We appreciate your feedback.
So again, if there are any questions or comments, feel free to unmute yourself and speak up, or you can type in the chat box. While we give folks a minute to submit any questions, if there are any. Do you have any last comments, Dr. Salazar, that you'd like to share before we close off? I think you're muted, Dr. Salazar.
I just wanted to thank everyone for listening and to I hope that our message got through, some of, if not all, that integrated services are excellent and are help, a tremendous help to the population that you guys serve in every status, because we also, as a healthcare providers, we have offices in Naples where we have also psychologists there that are, and the same answer is the same answer that we have here. We are extremely happy to have the collaboration of the behavioral health people to us. Thank you.
Okay, I see a question coming up. Do you find it necessary to match gender of behavioral health provider for clients experiencing ACEs, like sexual abuse? And so when we respond to any ACE, it really is the first available behavioral health provider, especially when we're doing it on demand. So in our unit, we at one time we could have 6 primary care providers, medical providers, and then we could have 2 to 3 behavioral health providers depending on the workload for that day. So it really is the person that's first available. We do give the patient the opportunity to ask for a different behavioral health provider, and it has happened before where a patient may ask for a behavioral health provider of a different gender, and we would have that discussion with the patient, especially during the screening process or as we're reviewing screening results, and we will try to accommodate that request. Sometimes it's hard to accommodate those requests for on-demand visits. So again, if there's a positive screening for sexual abuse, I may be the only behavioral health provider that's available. So I would do my best to try and do an initial assessment to determine if there's any current threat that we need to respond to. And then if there's a preference for a provider with a different gender, then we would make arrangements for the follow-up to be with a different provider. Let's see, I think there's another question. I'm trying to scroll through.
Yeah, I think a couple of questions popped up.
Okay. What option do you have for patients that don't know how to read or write when it comes to the computerized screening? Yes. So our software is designed so that if you are unable to read or write, you can still respond to the questions. We spent a lot of time programming the software. Because of that, we knew the needs of our population. And so we have audio prompts, and then we also have graphics that we design so that patients can still respond if they're unable to read. As a matter of fact, we're redesigning the software right now and are close to completion. We have a non-reader version of the software. So if there is a non-reader, we will not even display any text at all on the screening device. So there will be no text utilized. It'll be audio only and then graphics that we have designed. And before they begin the screening process, there is a brief tutorial that will teach kind of the basics of how to run through the screening system, which graphics to hit and how to touch the screen and that sort of thing. So we've taken that into account. Another question is, have you integrated peer counselors into any of your primary care practices to increase engagement in behavioral health services? We do not have peer counselors in our primary care practices. However, we did for a temporary amount of time because of some grant funding. We did have what we called health information brokers or adolescent health information brokers. One of our big initiatives is childhood obesity. So there were several years where we recruited and trained adolescents to be these health information brokers. We specifically taught them how to use technology to get reliable information to their adolescent peers about healthy eating, diet, and exercise. They would go out into the community to different community events to educate adolescents and to improve their access to reliable health information. They would also go into their schools and be ambassadors for the program. They were integrated into an obesity program that we have at the clinic. So that's probably the closest thing that we've had to peer counselors, but it was specific to adolescents. And the focus of that model was health information technology. Good question. Okay, I think we have maybe a couple more minutes left. If there are any other questions. Okay, I see one coming in. How many languages does the ACE screening available for the patients? So we have the ACE screening available in English, Spanish, and Creole. So those are the 3 languages where we have the ACE screening available. And again, we have that in audio format and then also in written format as well. Okay, there's another question. Can you talk about how you are currently working with schools to connect youth and families to behavioral health services? So we have a really good relationship with the local schools here. The way our local school system is organized, each school has a couple of key positions that we collaborate with most often. First, they have a coordinator for special education services that oftentimes we collaborate with. And then also every school has a mental health counselor / social workers that is assigned to the school. So we have a relationship with each of those 2 contacts at every school in our community. And so if there ever is a need that arises in the primary care setting, we know who to contact in the school setting. Likewise, they know how to contact us when they identify a behavioral health need. So that's just relationships, collaborative relationships that we have built with those community partners. However, right now, I mentioned that we are working to enhance the integrated care program in women's health. We're beginning within the next several months to screen expecting moms for ACEs and trauma. And we are identifying children during pregnancy that may be at risk for ACEs and or for developmental and early behavioral concerns. As part of that integrated care program, we are introducing to the primary care team a developmental specialist / consultant who will be part of the patient's care both during pregnancy and during early childhood, so over in pediatrics. That individual will do many things, but part of their work is that they will be a liaison to the early childhood education setting. So if in primary care, we identify a student who is at risk or has a particular need, this individual would physically leave the primary care setting and would show up at the child's early childhood education setting, so their school, their daycare, and would be available there to serve as a liaison between the primary care team, which would include the pediatrician and a behavioral health provider at a minimum, and then the school setting. So this individual would be able to float back and forth between the primary care setting and the school setting. SAMHSA actually has a model for how to do this. It's the early childhood consultation model. I'm sure I'm messing up the formal name for it, but SAMHSA does have a model for consultation during early childhood, where again, you would bring in a developmental specialist who can consult with the schools, who would be part of the primary care team, but can physically leave the primary care setting and go to the school setting. So we're excited about implementing that model in the coming 6 to 12 months or so.
Thank you very much, Dr. Rosado, Dr. Salazar. Wonderful presentation, a lot of great information, and I love the resources. Again, just a quick shout out to participants to please fill out the survey. The link is in the chat, and have a great day. Thank you.